Good morning. My name is Amanda Stapleton. I'm an associate professor of pediatric otolaryngology at Children's Hospital of Pittsburgh at UPMC. And this morning we're going to discuss pediatric nasal obstruction. I have no disclosures. The outline of our discussion today, first we're going to get into what congenital nasal obstruction can present as and what are its etiologies. Then we'll move into inflammatory infectious causes. We'll discuss structural and traumatic issues for children, as well as nasal masses and tumors. So pediatric nasal obstruction is very common and has a very wide differential diagnosis. The age of the patient and their clinical presentation really can help you narrow down the differential of pediatric nasal obstruction and hopefully get you on the right track for the correct diagnosis and the correct management. And inflammatory infectious disease is really the most common cause in most children, and we'll discuss what the incidence is and the management. So the first thing to talk about is congenital nasal obstruction. And this can come in two forms. Newborn nasal obstruction can often present due to choanal atresia or piriform aperture stenosis. And then there are also congenital nasal masses that can also lead to nasal obstruction. And these can come in the form of nasal dermoids, encephaloceles, gliomas, or nasolacrimal duct cysts. And so the problem starts out that babies are obligate nasal breathers, meaning that they have to have a patent nasal airway to be able to breathe and swallow at the same time. And it doesn't take it takes about 4 to 6 weeks before mouth breathing truly becomes the main source of respiration. And so you really have to stabilize the airways in these patients that present with nasal obstruction. And there are some options. You can use a McGovern nipple, which basically is a pacifier that you cut the end off of so that it keeps their mouth open to force oral respiration. You can use an oral airway. You could endotracheally intubate the patient. And if need be, tracheostomy is always an option as well if the patient is unstable and you're unable to secure a nasal airway in a short period of time. And so one of the common things that we'll see in the pediatric hospital is choanal atresia. And there's a couple different philosophies as to what this originates from. Typically in the 4 to 11 week of development, you have a buccopharyngeal membrane. And if that doesn't dissolve and open up, then you can end up with an extra atretic plate in the posterior nasal cavity, separating the nasal cavity from the nasal pharynx. You can also have excessive mesenchymal tissue that also could be the cause. And so how do you diagnose this? Well, typically it starts out with a NICU trying to pass an NG catheter or some other catheter through the nose and meeting resistance. You could look for an abscess of fogging under the mirror when you place it underneath the nostril. And definitive diagnosis is truly made with a CT scan or nasal endoscopy to confirm that you have a bony or membranous separation of the nasal cavity from the nasal pharynx. And so here's a CT scan of a choanal atresia patient. As you can see, the patient has a bony atretic plate here on the left side and a membranous plate on the right. And there's a lot of other anatomic abnormalities that can go with a choanal atresia. These include septal deviation to the obstructive side. You could have medial bowing of the lateral wall. Your pterygoid plates can be medialized. We typically see a very widened vomer in choanal atresia patients, as well as a narrow nasopharynx. And so here's another CT scan of a bilateral nasal choanal atresia, and these can be present in patients who have genetic syndromes. And as you can see here, we have a bony atretic plate, and then all the secretions that are unable to pass into the nasopharynx build up in front of those atretic plates and block the nasal cavity. Here's a great example of that septal bowing. You have a bony atretic plate on the right, and the septum swings all the way over to that atresia plate. And you can also see the pterygoids start to move medially as well. And again, another example of the right-sided choanal atresia, as well as the bowing of the septum and the medialization of the pterygoids. Unilateral are more common than bilateral. 50% are associated with a congenital malformation if you have bilateral choanal atresia. Right tends to be more common than the left. Bony atresias by themselves are only about 30% of choanal atresias, and actually mixed membranous and bony tend to be the most common. And here's an endoscopic view. So if you place a 120-degree camera into the oral cavity in the oral pharynx and look up towards the nasopharynx, this is an example of a bilateral atresia, and this is an example of a unilateral atresia. And so syndromes that are associated with bilateral are charge syndrome is the most common that we see it in. Treacher-Collins, Cruzon, and APERTURE are all have been described having choanal atresia as well. And so the other thing you have to think about in a newborn with nasal obstruction is piriform aperture stenosis. And what is that? Well, it's basically the medial process of the maxilla is so close and narrow that you're unable to get a nasal airway through the anterior portion of the nose. And so the piriform aperture is actually the narrowest portion of the nasal airway, and it really can cause significant nasal obstruction in a newborn and can be a difficult issue to deal with. You can't pass tubes, just like with choanal atresia. They can have episodes of cyanosis and feeding difficulty. And typically, if that width is 11 millimeters, which we'll show on the next slide, then it is truly a diagnosis of piriform aperture stenosis. And if it's less than 6 millimeters wide, these patients are 100% going to need a surgical intervention. And so here's a CT scan of a baby with piriform aperture stenosis. And so this is the width we're talking about, taking that medialmost aspect of the maxilla and measuring it from side to side. This one is 6 millimeters. And as you can see, the septum itself takes up 3 to 4 millimeters of that same airway. So this child has no space to breathe through and is going to present with nasal obstruction. Well, what do you do? Well, for either patient, you want to, again, establish an oral airway. You can try and put saline or Afrin in there. You have to be careful with nasal steroid drops. You don't want to have the patient go into having endocrine issues because you're giving exogenous steroid. We have had that happen in newborns. You have to get a preoperative CT to really see what your bony margins are and what your anatomy looks like. And if there's a central incisor in a piriform aperture patient, then you need to get an MRI, because there is a constellation of syndromes called holoprosencephaly, where if there's a central incisor, this may be indicative of a holoprosencephaly patient, which is basically when the brain doesn't divide into the right and left lobes correctly. You again are getting your CT, and in some patients you want to do a cardiac workup as well due to the high incidence of association with other congenital syndromes. Okay, so once you've identified and diagnosed the patient, how do you fix it? Well, choanal atresia repair has really moved into the endoscopic era. And so we're going to go through a couple quick pictures and videos of what a repair looks like. So typically we'll bring the patient to the OR, suspend them with a Dingman mouth retractor, or you can use a MacGyver. And you can put a 120-degree camera in through the palate retractor, and you get this beautiful view of the posterior choana. And as you can see, this patient has a left-sided choanal atresia. And so the next thing that I do is I look with a 0-degree endoscope into the nose to identify the atretic plate. And then you can use ureteral sounds, which are small dilators that you can use to puncture the plate so that you know that you're heading in the right direction. And you can do this under direct visualization. And so you can use ureteral sounds. Some people use Hager cervical dilators, but for small babies, I tend to use the ureteral ones because they're much smaller. And I like the angle because you want to curve down and not go up into the skull base. And so really monitoring your trajectory when you're opening up an atretic plate and making sure you're heading down into the nasopharynx and oral pharynx and not high up into the skull base. And so here's the endoscopic view where you have that ureteral sound coming through the atretic plate under direct visualization with your endoscope. And so then how do you open up the nose? Well, typically you want to raise a mucosal flap to preserve mucosa over the repair site. So that way, when you're finished opening up the nasopharynx, you have nice healthy tissue to lay down to prevent scarring. So you can do a formal nasal septal flap, but I find that you can, make an incision and back elevate and save a lot of good mucosa for at the end. And so this is just a cartoon drawing where you make an incision through the mucosa overlying the atretic plate, and then I back elevate these onto the lateral nasal wall. You can save a little bit on the septal side, but you're going to be taking out that back vomer. So really you're trying to get as much off onto the lateral nasal wall and on the rostrum of the sphenoid to preserve it for repair at the end. And then I would actually take this incision all the way down and again, back elevate all this mucosa across so that you can save it. And then you can either drill it with a small diamond drill. You could use a backbiter to remove the aspects of the vomer, and you really want the vomer flush with the nasal floor. I try and also create more space by drilling the medial pterygoids. You need to make sure that you know where the sphenopalatine artery is in the posterior nasal septal branch to make sure you're not causing significant blood loss. And then you need to reposition the mucosal flaps after you've removed all the excess bone and membranous tissue that was creating the atresia. And so this is kind of where it looks like if you're looking from the nasal side or from the oral side where you're looking up your 120, you can drill along the back, take down your atretic plate. And this is what it looks like at the end of the case, where you've created a large opening. You're laying your mucosal flaps from the lateral wall back over your atresia. And then I tend not to stent these patients. This is that same nose healed at approximately 1 month postoperatively. Post-op care, to stent or not to stent. This has been an area of debate for a long time, and a recent meta-analysis showed that it really doesn't matter. I try not to stent because I find that it can cause significant issues with nasal septum, nasal columella, nostrils, especially in small babies. However, if you have a bilateral charge patient and you really need to make sure you have a nasal airway, you might want to leave it in for a week. It does give you a way to deliver saline and Ciprodex to the nasopharynx, but I tend to not stent. Everybody kind of has their preferences. Piriform aperture stenosis repair, you have two options. You can dilate it, which is basically trying to get the bone lateral as well as it's out fracturing the inferior turbinates. So that way you're creating more of a nasal airway along the floor. Some patients will need a sublabial drill out to really remove all that excess bone to create as much space as possible. And then I always do a direct laryngoscopy and a rigid bronchoscopy to look for secondary airway lesions to make sure there's no other issues with their upper and lower airway. And so, again, you want to use nasal endoscopy. You can use cervical dilators or ureteral dilators. You go slow, you start small, and you slowly advance them and see if you can get up to 6 millimeters per side. I tend to stent these afterwards because after you've created this dilation pathway, you don't want it to scar back to the septum. And so I typically will take very small endotracheal tubes, cut them to size, and use them as stents for up to 2 to 3 weeks. The sublabial drill out is when you make a incision in the sublabial region, you lift up the mucosa, you get along to the nasal floor. And the key is to make sure you don't puncture the nasal mucosa. And that's what this surgery looks like. You're making an incision, you're getting right to that, most medial aspect of the maxillary bone, drilling out as much of a triangle as you can here. And again, the key in this surgery is making sure when you're doing your elevation that you stay off of the nasal floor and make sure that you're preserving that mucosa. Again, so this is just detailing, taking that down. Okay, so moving on, what other things can present with nasal obstruction? Well, congenital nasal masses is definitely on the list. And these babies can present with masses coming from the nasal cavity. Again, you still have that obligate nasal breather problem, and they will present with cyanotic feeding. They can have typical cyanosis whenever they cry. It's hard to pass a catheter again, and sometimes you'll see external nasal deformities and soft tissue edema. And so how does typical nasal development happen? Well, in the early first trimester, you'll have a normal dural diverticulum that comes down through the foramen cecum into the prenasal space. That same dural diverticulum is supposed to involute and come back up, which you see here in figure 3. And that's how typical development happens. What happens is when you have either a nasal dermoid, encephalocele, or glioma, you have some area of failure of involution, and that can lead to a variety of congenital lesions. And so, for example, when you have an encephalocele, you can see that as that dural diverticulum came down, it stayed, did not involute, and now you have CSF, neural tissue, and dura in the prenasal space. A glioma is a connection with no neural tissue within it, and then a dermoid also can be trapped mesenchymal and ectodermal tissue. So the dermoids are the most common. It's truly what we see them the most often in the hospital, and they're ectodermal and mesodermal tissue, and they can contain all structures of the skin. And so I typically call these the cholesteatoma of the nose, meaning they have that white, cheesy, kind of sebaceous tissue within them. And if you don't get it all out, it just keeps coming back. And so they typically can present with a slow growing mass in the midline of the nose, typically over the dorsum, but it can kind of track it anywhere from the radix down to the tip. And this is what it happened, or how it looks like on a kind of schematic drawing, where you have this excess tissue that's coming down through the foramen cecum into the prenasal space, and sometimes can come all the way out to the skin where you have a pore that drains fluid or can grow a hair. And then this is also what that similarly looks like on MRI. This is another nasal dermoid. Again, you have a fluid, bright lesion that you can see kind of in that prenasal space. It sits in between the nasal bones. It can make the nasal bones spread, and you can get cosmetic issues from it. And this is a 3D model of a pediatric patient of mine who had significant intracranial and extracranial nasal dermoid. We printed out the patient's anatomy in clear resin and then painted the dermoid in yellow here. And you can see it extends pretty high up along the frontal bone, comes down. Here's her skull base defect as it comes through the skull base. And then she had significant nasal and all the way out to the skin nasal dermoid. So really a large and long lesion. And this is her CT scan. You can see this large defect in the skull base as the dermoid is coming down through the skull base into the nose and out to the tip of the nose. And here's again a nice coronal view of that as well. And here's just a quick video of some operative technique with nasal dermoids. There's a lot of different ways to approach these depending on location, how high it is on the nose. Does it involve the super tip? Is there a pore up high at the radix? Is it along the dorsum? And endoscopically, you can go in and find the connection between the internal nose and the nasal cavity. Typically, I'll do a small anterior septectomy so that we can find the pathway as it's coming and splitting the nasal bones. Here's where we found it at the skull base. And then you can see that cavity where all the sebaceous debris had been trapped. We cleaned all that out. Then you repair the skull base, a lot of times using just a middle turbinate free mucosal graft. Here's the little pore that was on the outside. Here we're probing it to see where, the direction. A lot of times I'll take a lacrimal probe and kind of follow the tract. And in this case, basically just coring out the small area around the outside of it. Sometimes I'll do an external rhinoplasty approach if this tip is down low, but you can see you still have that sebaceous material that was within the tract itself, and you have to make sure you get all of that out, otherwise it will just come back. Encephaloceles are different. They're extracranial, meninges, CSF, and neural tissue. They can present without herniation of brain tissue, and they can be external or internal nasal masses, and they're really described by their location. So they can show up in your office with a baby who has a pale growth. It can be pulsatile, it can be compressible, and more importantly, you have a positive von Furstenberg sign, which is basically when it can be triggered by crying or straining because you're expanding the jugular vein. This is what it looks like, again, on schematic. So a sinusital encephalocele is kind of up here at the level of the frontal bone. A basal encephalocele, it has come down through the anterior skull base and really, right to the nasal dorsum, similar to a dermoid. This is an 8-month-old baby that we had that had an extranasal and intranasal encephalocele. Again, a significant external component. This is his 3D printed model, where again, we use clear resin for the bone, as well as painting his lesion green. And here you can see the skull base defect where it kind of originates on the anterior frontal, goes through that foramen cecum, widens that whole area, and then comes out onto the external side. And his right nasal bone was significantly lateralized as the encephalocele kind of pushed through there. And so he underwent a combined external and endoscopic resection. And this is him 1 week later when we were taking his packing out. I repaired his skull base defect with a flap, and his cosmetic closure was very favorable. We were happy we were able to primarily close him. And now he is 6 months out and doing very well. And a glioma is basically an encephalocele without an intracranial connection. And they are labeled different things. They can be called glial heterotopia, nasal cerebral heterotopia, basically, neural tissue in the wrong spot. And so similarly, they can present in different locations. Here's a baby where you can see the lesion or the nasal glioma kind of coming lateral to the nasal bones and through the frontal. This is what it looks like on imaging. Here's another one kind of coming through that same kind of trajectory pathway through the foramen cecum, down through the fonticulus frontalis and into that prenasal space. And those require excision similar to what we discussed. And one other thing you can see in your office frequently is a nasolacrimal duct cyst. And these are probably more common than everything that we just discussed. And what they show up with is either patients with significant eye tearing or eye infections. And you look in the nose and you'll see a cystic mass that's along the floor. Typically, you can slide a scope posterior to it, and it tends to be compressible. Typically, they'll start out with medical management, meaning trying to do some warm compresses and facial massage just to open this up. But a lot of times we'll do endoscopic probing, and then we marsupialize the cyst endonasally. Okay, so moving on from the congenital lesions. So now as we're starting to deal with children who start to go to daycare, who start to go to preschool, who start to go to elementary school, they can present in your office with nasal obstruction. And so the question then becomes, what is your differential and how do you work up and evaluate these patients? So we're going to discuss allergic rhinitis, adenoiditis, and adenoid hypertrophy, recurrent upper respiratory tract infections, which is probably the most common thing that patients have, especially in the daycare population, and then acute and chronic rhinosinusitis. So allergic rhinitis is a IgE mediated disorder when you have inflammation after you're exposed to a allergen. And in kids, they can present as nasal congestion and clear drainage, some sneeze, some itch their eyes, and it's broken down into seasonal, which is described as when you're sensitive to pollen, grasses, or trees, which tend to be more common in kids, or perennial, which is when you have a sensitivity to dust, mold, or animal danders. And so allergic rhinitis is very prominent in the pediatric age group, and it can go all the way up into the teenage years. It's about 20% of the US population, and it's the most common chronic disease of childhood. And the timeline is, this is kind of a typical chart of an allergic march. In the first year of life, you really deal with food and sensitivity as well as eczema. Then you start to get a peak as asthma starts to become an issue in the 3 to 5-year-old age set. And then you start to see this other red line here where allergic rhinitis starts to kick in around age 5, and then really starting to peak in the early preteen years and kind of stays high into the 20s. And so that's when you really are also thinking about allergic rhinitis management in children. And so history is really your most important aid. When do they get symptoms? What are their symptoms? Do you have any suspicions? Every time you go outside and mow the lawn, does your kid come in with swollen eyes and drippy nose? If you go pet a dog, are they, draining for a week afterwards and can't sleep? All these things help you give clues to what your diagnosis is. What happened when you gave them, an antihistamine? Did it improve? Is there significant family history? Do both parents have significant allergic rhinitis or asthma? All these things are very important to decide where your management steps are going to be. And they tend, again, to have clear rhinorrhea, congestion, pale mucosas, sometimes there, sometimes it's not. And I always ask about eczema and asthma as well to see if they're truly atopic children. And so if you have a suspicion of allergy, you can, do formal testing, skin prick testing, RAS testing, dermal testing, depending on what your resources are in your practicing location. But you're still going to want to manage them medically as, using antihistamines, using nasal steroid sprays. You have the option of antihistamine nasal sprays, as well as things in the Montelukast category. And so the next thing I think about in kids who present to my office with nasal obstruction is adenoids. And adenoid hypertrophy can present with snoring, mouth breathing, chronic drainage, chronic cough, postnasal drip. And so I'm always in the back of my mind thinking, okay, does this kid have enlarged adenoids? And this is a nasal endoscopy of a child who has really sticky mucus. You can see kind of all the, kind of sticky mucosal bands. And then when you get to the back of the nose, this patient has 100% obstructing adenoids. They are filling the entire nasopharynx and even coming into the posterior nasal cavity because they're so big. And so you can see him try and breathe there through the bottom. This is a flexible scope that we performed while awake, but definitely a child with significant adenoid hypertrophy. And this also leads to troubles with otitis media with effusion and recurrent otitis media, because if your eustachian tube is completely blocked by a large group or a large adenoid bed, then it really makes it hard to drain your ears. And let's see, we just watched this. So the other thing you have to think about on physical exam is what's happening with their inferior turbinates. When you look in a patient's nose and the inferior turbinate is touching the septum, you know that this child is not breathing well through the anterior nasal cavity. And so if you remove the adenoids, but you still have huge inferior turbinates, they're still going to show up in your office and say they can't breathe. So you really have to think about allergic disease, inferior turbinates, and typically if the patient has been on good allergy management with sprays and oral antihistamines, and still has enlarged inferior turbinates, I will consider reducing the inferior turbinates when doing an adenoidectomy or another concomitant procedure. So again, treatment for all these things, second generation antihistamines, topical nasal steroid sprays, antihistamine nasal sprays, anti-leukotriene modulators, and then the only disease modifying is discussing immunotherapy with the family and talking about it with your allergist to see if it's a reasonable option based on their allergic profile as well as their maximal medical management. All right, so again, moving on to adenoids, and patients can present with chronic adenoiditis. A lot of times you'll have people show up in your office and the parents will say that they have sinusitis, but the patient's only 1.5 or 2 years old. And so really what's happening when they get these purulent nasal episodes is that they're getting infections of the adenoid bed and really treating kind of chronic adenoiditis. And so in younger patients under 5, really considering the adenoids as a location of biofilm formation, chronic cough and postnasal drip, as well as the nasal obstruction that adenoid hypertrophy can cause is really important for your workup. So again, this is that photo of really enlarged adenoids kind of filling the entire nasopharynx and causing nasal obstruction. When I walk into an exam room and I see the kid sounding like Darth Vader where they're breathing and they're not actively sick, adenoids are clearly on the front of my mind. And so the other thing that we're going to discuss briefly here is pediatric chronic sinusitis. Acute sinusitis is typically presenting with fever, headache, purulent nasal drainage, and typically falls after a upper respiratory tract infection. And those are treated with antibiotics in the short course, meaning 10 days, amox or augmentin, and really trying to deal with an acute course. Chronic sinusitis is really a different animal, especially in children, because you have to have all these symptoms for greater than 12 weeks with no symptom-free intervals. And so really getting a good history and truly doing a diagnosis of chronic sinusitis can be more challenging in the pediatric age set. But you have to have 2 of the following, which is nasal obstruction, congestion and drainage, facial pain, cough, or changes on endoscopy and CT that are consistent with chronic sinusitis. And so there was a consensus statement put out by the AAO-HNS in 2014, and they kind of broke down chronic sinusitis in kids and really said, okay, if you're thinking about treating chronic sinusitis, you really have to go after allergic rhinitis in the older patients, consider adenoids, which we just talked about in the younger patients. And then again, the ability of the adenoids to act as that bacterial reservoir is really important. And it doesn't matter if the adenoids are big or not, meaning you have to get rid of that that biofilm that's sitting on the adenoid bed. You're trying to get that ecological niche of the nasopharynx back to normal and get rid of whatever chronic bad bacterial players are there throwing it off. And so size does not matter when it comes to treating chronic adenoiditis. And so again, kind of thinking about these key points. When you're talking about older children, kids older than 12 are different than kids younger than 12. It's definitely worthwhile to scope these patients to make sure that you know what you're dealing with, make sure there's not any polyps, adenoid hypertrophy, other changes within the nasal cavity. And if you do see nasal polyps in the nose, then you need to be thinking about something else, which we'll go into later on. So what's the first line therapy for chronic sinusitis? Very similar to allergic rhinitis. So nasal steroid sprays are your first line. I use nasal irrigations in all my patients. I use pediatric size bottles. I have them watch YouTube videos, whatever it takes to get them to rinse their nose. Decongestions are contraindicated, and I will use antibiotic saline irrigations in kids who have already had sinus surgery, who were able to do nasal cultures in the office and then treat them on culture directed data. And so what are your surgical options in kids? So again, starting with adenoidectomy. If they fail adenoidectomy, I typically go to endoscopic sinus surgery. There's not a lot of great data about balloon catheters in kids, whether it's truly beneficial or not, versus just doing regular sinus surgery. And so I tend to do an adenoidectomy. If you fail that, then I move on to endoscopic sinus surgery if you have CT findings and have failed maximal medical management and adenoidectomy. Okay, so moving on from the infectious inflammatory and starting to think about other structural things that can cause pediatric nasal obstruction. Septal deviation, nasal bone fractures, and foreign bodies are all kind of in that category. This is just another quick video of a 13-year-old. She has some mild inferior turbinate hypertrophy. She has a slight septal deviation into this left side of the nose with this, this septal shelf. She's got a small concha bullosa of the middle turbinate, and also presents to my office with left-sided nasal obstruction complaints. So talking about, who do you do a septoplasty on? Well, they're typically caused by congenital issues as well as traumatic. Kids hit their face all the time. When they're learning to walk, they fall and face plant. When they're learning to ride a bike, they run into something. When they're playing sports, they are learning to catch a ball, it hits them in the face. So kids hit their nose all the time. So having a mild septal deviation from impact or injury is very common, and typically, is not why they're in my office. But you will also run into those really impressive septal deviations where they are completely deviated off into one side and truly are symptomatic from it. And so I tell parents that septoplasty does not affect facial growth. And there was a recent meta-analysis in 2020 that or a systematic review, sorry, that looked through that, and no studies have really shown that septoplasty compromised mid-facial growth, and that will affect how their face, their mid-face, or their septum shape will change, or will not grow to its full potential. And so I think septoplasty is a great surgery when symptoms match anatomy, meaning if they come in and say that the left side of their nose doesn't work and they can't breathe through it and it's driving them crazy because they can't run on the soccer field or breathe at nighttime. And when I look in their nose and they have a large septal deviation into that left side, then it's very reasonable to do a septoplasty on these patients. And so because we're in the pediatric realm, we also have to think about foreign bodies. And as I tell my residents, unilateral nasal drainage in a pediatric patient is a foreign body until proven otherwise. Meaning, if they come in and they have thick purulent drainage coming out of one side of their nose and parents can't figure out what's going on and it smells really bad and it hasn't been getting better with antibiotics, there's something up there. And so performing a nasal endoscopy in the office and removing it is the fastest way to get to the right answer. And so we pulled all kinds of interesting things out of noses over the years. And so it's always on my mind if we're talking about unilateral nasal obstruction and drainage. Okay, moving on to our last category of nasal obstruction, pediatric masses and tumors. And so when I think about pediatric masses, there's a couple of different kinds. Nasal polyps, which are a distinct entity, and then there are benign and malignant sinonasal tumors. So first we're going to talk about nasal polyps. So if I look in a nose or do a nasal endoscopy and I see unilateral nasal polyp, similar to this picture down on the left, I am thinking more along the lines of an antrocoinal polyp. These are, fairly common in children, typically not until age 10 or greater, but they can grow to significant size, meaning 6 or 7 centimeters. They can occlude the sinus drainage pathway on that side of the nose or in the sinuses, and are easy to remove, and can be a straightforward fix. If I look at a nose and see bilateral nasal polyps with thick mucus and yellow-green drainage, then I'm really, my alert sign for cystic fibrosis is very high. So if I truly see a clear small polyp, and if they tend to be on both sides of the nose, then I'm immediately ordering them a sweat test and talking to my pulmonary colleagues to see if this patient has cystic fibrosis. You also have to think about, does this person have very severe allergic rhinitis? Some patients with severely poorly controlled allergic rhinitis, even in the pediatric world, can have significant nasal polyps. And so you can consider allergy testing, skin testing, RAS testing, et cetera, to work them up. And then do they just have chronic rhinosinusitis with polyps? That comes as well. But truly, anytime I see a nasal polyp that's not an antrocoinal polyp, even if I'm suspicious of allergic or just chronic disease, I still am getting a sweat test to make sure that we're not, a atypical CF patient that isn't diagnosed until later in life. And so this is a 8-year-old with cystic fibrosis who has had chronic rhinosinusitis since age 3 or 4. He's previously undergone a medial maxillectomy and sinus surgery, and his polyps have continued to grow. And so this is what CF nasal polyps and chronic sinusitis look like. As you can see, he's already had a medial maxillectomy, so the posterior one half of the inferior turbinate is gone, as well as that lateral nasal wall, and yet he still has thick yellow-green drainage and polyps. And if you're seeing anything that looks similar to this, you need to be talking to your pulmonologist and getting a sweat test. I can show you the other side here similarly. And again, this is what I mean when I think of it: sticky mucus, yellow-green drainage, polyps that look, kind of more mucoid, filling spaces, fill with a lot of secretions. This is, a high index of alert for CF, especially in the pediatric world. All right. So moving on to our last category is neoplasms. In kids, if you have a male who's over age 10 who's having unilateral epistaxis and nasal obstruction, you need to be considering a juvenile angiofibroma. There can be dermoids that are missed. You can also have strange things like, salivary gland tumors that are benign, or neurofibromas. In the malignant category, I have seen esthesioneuroblastoma in teenage boys. They present with a large unilateral mass, and you think it's a JNA, but again, you have to make sure that you're getting imaging to find out where it's really coming from. Lymphoma can present with nasal obstruction, either in the nasopharynx, typically in the adenoid bed, and rhabdos also, unfortunately, can arise in the sinonasal cavity, and we've treated patients with rhabdomyosarcoma of the sinuses as well as the nasopharynx. And so just having your kind of alerts out there that things could be, worrisome, always doing a full endoscopic exam as well as getting imaging on anything that looks suspicious will hopefully help you kind of diagnose these correctly and then move on to management. So our conclusions today is that pediatric nasal obstruction is very common and has a very wide differential diagnosis. Your age of your patient and how they're presenting can really help you narrow things down quickly. Congenital nasal obstruction is a respiratory emergency in some cases, and you really need to secure the airway first before you consider additional workup. Inflammatory infectious disease is really the most common in this age group, and so always the first thing on your mind. The key points here are, again, secure the airway in a newborn. Imaging is really the key to workup in congenital nasal masses and obstruction. Making sure that you're getting imaging before you're biopsying or doing any kind of surgical intervention is essential. 20% of pediatric patients have allergic rhinitis, so you really have to have that in the forefront of your mind and know how to manage that correctly. Adenoidectomy truly is the first surgical line therapy for chronic adenoiditis and chronic sinusitis in kids, and it can be a main contributor to nasal obstruction in children under 10. Unilateral nasal obstruction and drainage is a foreign body until proven otherwise. And if you see nasal polyps in children, you should be evaluating for cystic fibrosis first before any other interventions. Here are some of our suggested readings and some of our references. And I hope that this talk was helpful for you today. And feel free to reach out if there's additional questions. Thank you.